10 minutes, and that includes questions, so hurry up.
Thank you very much. Good morning, everybody. So I've already overran before starting, so let me apologize for cutting through a coffee break, and then that shuts these two up as well, isn't it? So, friends and colleagues, a great pleasure to be here to present you the long-awaited results of this phase 3 trial of DcVax in glioblastoma. Really good to be here, and really good to see everybody face-to-face. It's been a very, very long time, especially for extroverts like me. So these are my disclosures, and I mean, the current audience does not need to be told about glioblastomas. It suffices to say this is the most malignant tumor known to man, and I totally agree with Rajesh too, and he said yesterday that this is never going to be a purely surgical disease. It is an infiltrative tumor, and as surgeons, no matter how good we are, we're never going to be able to cure this condition on our own. Also, it's an extremely heterogeneous condition, which means that blanket forms of treatment, like blanket radiotherapy or chemotherapy, also will never give us the full answer. And this is totally crystallized in the poor outcome of these patients despite the standard of care. So as you all know, standard of care was established about 17 years ago by fantastic work of Rajesh too, which showed addition of temozolomide to radiotherapy and surgery gained us 2.5 months of added survival. Despite this, obviously, the survival remains very poor. New diagnosed GBM, 15, 17 months, they always recur, and when they do recur, the median lifetime is only 8 months with very few long-term survivors. But let me tell you, this is not because of lack of trying. So if you look at this review article published a couple of years ago, there have been over 400 trials recruiting over 30,000 patients using a whole range of therapies, CAR T-cell checkpoint inhibitors, etc., with unfortunately no significant improvement in the outcomes. And perhaps the one that we remember most in the most recent times was this ACT4 trial. We were recruiting actively to that from King's. Early phase trials look very promising, and when we got to phase 3, unfortunately, that promise was not replicated. There have, however, been few positive signs. So this nice work on tumor treating field with Roja and colleagues showed that addition of this local treatment to temozolomide gained about 2.7 months progression-free survival. The one requirement, however, is for patients to wear this TTF device for over 18 hours, and compliance, therefore, can be a problem. I do refer patients for this therapy, but I think to make this more mainstream, we do need to make it a bit more patient-friendly because it's hard to wear this device for 18 hours, at least a day. Those surgeons from my generation, including our chairman, remember well about carmosine wafers. So, when this came on, I got approved by NICE for new diagnosis, not recurrent GBM, on the data that showed 2.2 months survival. We got all very excited. We started using carmosine wafers quite regularly, but the problem was with surgical complications. So you have to have at least 90% resection. You must have a good dural closure, otherwise you get leakage of chemotherapy. You have to make sure you don't enter the ventricles. So overall, that kind of fell off the fashion, and we don't really use it very much nowadays. So what does that mean? So that means that for new onset GBM, we haven't really had any significant impact on survivals for 17 years. When it comes to recurrent GBM, it's even worse. For 27 years, we haven't had anything to really shout about. And this is why I'm hoping that I can excite you about this DcVax trial data, as excited as I am. So let me just take you over the trial overview. So what is DcVax? So it's autologous dendritic cell pulse with autologous tumor lysate, which is then injected through a series of intradermal injections. In terms of trial design, this was a double-blind randomized trial with crossover, and I'll come back to this crossover issue in a minute. In terms of our primary endpoints, this was initially defined as progression-free survival, but then later was changed to overall survival, and I'll come back to that as well in a minute. Very large study, so 331 patients, truly a multi-center study in 94 centers in 4 countries, and the timeline, which was quite long for various reasons. We had to stop and start again, partly financial, and most recently because of COVID, but that prolonged, if you like, cycle of the trial did give us some learning that then was fed back into the trial as well, and I can discuss that for you too. So how does this work? So this is a surgical form of immunotherapy, which is why myself as a surgeon could be interested. So the first step is to operate and take patient's own tumor out, and then that's processed to produce a lysate. Once we have that, then the patient had an apheresis. You extract the dendritic cells from the patients, and then once the manufacturing has been completed and you have the DcVax vaccine, that is injected through a series of injections intradermally. And the idea is that the dendritic cells, which are antigen-presenting cells, will then introduce those proteins from the tumor to T cells, which then replicate and eventually infiltrate the tumor and produce an effect. So in terms of study design, as I mentioned, the first stage is surgery, and typically 3 weeks after surgery, when the patient is recovered, we have the leukapheresis. It's important for them to be off steroids, so that gives us time for them to come off the steroids as well. And then there is a sort of 6 weeks or so of the concomitant chemoradiation, which is 2 protocol, and while that's happening, that gives time for the vaccine to be manufactured. Then there's randomizations, and once the vaccines have been made, some patients get placebo, some patients get active vaccine, and that's given through a schedule. So the first 3 are given about a week apart, and then that interval gradually increases 2 months, 4 months, 8 months, and so forth. So let me come back to this crossover design, because I know when we first published the interim data, that generated a lot of discussions, and only yesterday with Paul Grundy, I was discussing the same thing again as well. So let's step back. We don't live in an ideal world. Unfortunately, there are many barriers to research, and one of the biggest barriers in neuro-oncology is recruiting patients to come forward and be enrolled into our trial. And you heard from Roger yesterday that many patients, particularly when it comes to new agents, they do not want to come and enter a randomized trial because they fear that if you get randomized to the placebo cohort, placebo arm, they're not going to get active drug. And only a couple of weeks ago, Brain Tumor Charity, we were discussing this, and presently, really only about 10 to 15% of patients who are suitable to enter into trial for brain tumors are actually entering. So one way to overcome that is to have this crossover design, so at least patients have the hope of getting the active ingredient if the tumor progresses. Now, ethically, if we felt that that was particularly relevant for DcVax, because this is an interventional trial, so patients do have to have apheresis, leukapheresis, and leukapheresis does have risks. You can get thrombophlebitis, you can get thrombosis, you can get infection, and therefore, if you're putting a patient through an intervention, then at least they need to give them the possibility of receiving the active ingredients if they progress and they can cross over to the treatment arm. As I mentioned to you, the initial endpoint was progression-free survival, but then this was changed to overall survival. And there's a good reason for this. So when we think about pseudoprogression, because at that time pseudoprogression wasn't really understood. Now over the years, we know many treatments can cause pseudoprogression. So that's appearance changes on the scan that may look like tumor progression, but actually they are probably a good thing because of the effect of treatment. So we know many treatments can cause pseudoprogression, but particularly immunotherapies can do that. This slide is courtesy of Linda Liao, who is the American chief investigator of trials. And you can see from her work that the T cells do infiltrate the tumor, and therefore that can manifest as changes on the scan. So when you're looking at the scan in the context of immunotherapy, if you see a change, you cannot be sure whether that's relevant, i.e. that is because of a tumor change or it is because of the effect of the treatment. And clearly, when you have uncertainty about your endpoint, you cannot use that endpoint to measure your trials. It's important to also say that that change of progression-free survival to overall survival endpoint was not happening at the end of the trial. That happened throughout and before the data was unblinded. So this is important because once you have changed your outcome from progression-free survival to overall survival, because the study has a crossover design, means that the vast majority, about 90% of the patients, did have the DcVax. And therefore, that means that you can no longer use your internal control in the study to make a comparison. You have to use external controls. So what are external controls? So these are series of control patients from contemporary studies. So they are not historical controls or historical trials. There are a series of patients from contemporary trials that have been matched to your index study with a set number of pre-agreed terms. So this concept, just to say, is not new to DcVax. So there is a growing understanding that we could potentially use external controls, and the paper above from Patrick Vance and his group just discusses that concept. And we have been doing the standard type of trials for a very long time, and sometimes we do have to stand back and think outside the box. I think the UK, we are proactive in that because we're already doing adoptive trials. So brain cancer, Tesla brain matrix that Colin leading, and we're all actively recruiting to, for example, is an adoptive form of trial to maximize the data you can get from your trials. And using external control is another way of trying to maximize the data you can get when you can no longer use your internal controls. And although the field is being generated and activated for the clinicians to think about external controls, is also already being adopted by the FDA and the funders, and the paper below is an article by the FDA just going through the utility of external controls. So how did we choose the external controls? This was done through a cohort of independent experts who look at the range of contemporary trials, contemporary to DcVax, and match those with 14 criteria that match the DcVax trial. And on that basis, they chose 5 trials which looked at the new onset GBM and 10 trials that look at recurrent GBMs, and use the control arms of those trials to compare with the active arm of DcVax. And there were a number of sensitivity testing to make sure these are all correct in terms of selecting. So these are the trials that were selected. On top, we got the 5 trials which we use as comparators for the new GBM, and on the left-hand side, you have the 10 that we use for recurrent GBM. Just like we did, they're all well-known trials, you've probably seen most of them already, but just like to draw your attention to the top one that looks at the new onset GBM. Now, if you look at the median overall survivals, you can see no matter what we throw at this tumor, the median survival seems to be fairly static, around 16 months plus or minus 1. So regardless of the novel agent that you're using, actually the outcome don't seem to be effective until now. So what is the statistical plan then? So for the DcVax arm, the primary endpoint, we compared 232 patients who had DcVax at a new diagnosis and compared that with 1,366 external controls. Secondary endpoint for the recurrent GBM, 64 patients who had the DcVax on recurrence, on progression, that is, compared to 640 external controls. So let me report to you the data. So I'm happy to confirm that the primary endpoint was achieved, the secondary endpoint was achieved, and what was very interesting was how safe this treatment was. So in over 2,000 DcVax injections, we had only 5 what we can consider as severe adverse event possibly related to this treatment. What we were concerned about were things like cytokine storms or autoimmune reactions, which we thankfully did not have in this cohort. So just to look at these slightly more details, so for new onset GBM, what we found was that the median overall survival was increased to 19.3 months from randomization, so that's 22.4 months from surgery, compared to 16.5 in the controls. Now, this is around 3 months added survival. And if you look at this cohort, which were MGMT methylated, this was significantly more, so around 9 months advantage. So the same way that the MGMT methylated tumors seem to respond well to chemotherapy, it also seem to respond better to immunotherapy as well. Now, what was very interesting was the survival tail. So when you look at the 5-year survival, there were twice more patients alive in the DcVax cohort compared to the controls. What is also very interesting, we found that those subgroups of patients, such as the older patients, which we traditionally look at having a less favorable outcome, tend to also respond better with DcVax. Let's explore those a little bit more. So that's the Kaplan-Meier curve, and you can see the DcVax shifts that curve to the right, so to a better survival outcome. Now, this long-term survival tail is interesting. So as you move on from 36 months towards 60 months, you can see the difference between the DcVax cohort and the control arm increases, whereby by 5 years, you got more than twice more patients alive in the DcVax study rather than the control group. So we looked at the characteristics of these long-term survivals. This is a very primary look at this, and there's a lot more to do. But as you can see, the vast majority of those patients who do well have got the known good prognostic factors. So they have had a better resection, they are methylated, they have had a better KPS score, but not all. And there are cohort of patients who don't have those known better prognostic factors, we still do well. So I think we can learn a lot about the biology of GBM by looking at this data in more detail. And again, I agree with Roger that lots of this is because of biology. So we need to look at the biology to see what's going on there. I did say to you that those cohorts that we traditionally look at as less better responders seem to respond more pronounced to DcVax. So in this graph, we compare those patients who are over 65 compared to less than 65. As you can see, in both cohorts, we got significant improvement with DcVax. P-values are there for you to look at, but the difference seems to be greater in the over 65 cohorts. And again, we see that long-term survival curve in over 65s as well. The concept of residual disease is important. Obviously, as a surgeon, when we go to theater, we always want to achieve maximal resection, but life is not perfect, and occasionally we cannot achieve what we want to achieve. And everybody is advocating. How about for recurrent tumors? Even more pronounced data. So remember, for 27 years, we have not had any data for any intervention, including for repeat surgery, to show there is benefit for the patient with recurrent GBM. But in this cohort, we have almost 6 months survival advantage in patients who have had recurrent GBM. And again, you can see the long-term survivors as you go over the years, that becomes more and more pronounced. Just showing you the Kaplan-Meier curve, and again, you can see the significant shift to the right with better survival, both median and also long-term. And again, as we go across from 6 months, 12 months, eventually 30 months, we can see there is increased survival difference. And again, at 30 months, there's over twice more patients alive in the DcVax cohort as there are in the controls. And again, the same pattern when you look at the characteristics of these patients, many of the known characteristics, favorable characteristics are present in the better survivors, but not all. And therefore, again, there is something to learn here about the biology of GBMs and what's going on there. So just to finish up, actually, that's not too bad. I was worried I'm going to completely overrun. So just to finish up, so it's the first phase 3 trial of a systemic treatment to show survival advantage in about 70 years since the seminal work of Roger. It's the first phase 3 trial to show any improvement in 27 years for patients with recurrent GBM. And of course, what's very interesting is that long-term survival time. And for me, the fact that we have those cohorts of patients traditionally thought to have worse prognosis, to have another option is also very, very relevant. But I don't think this is just it. I think there's future horizons and many opportunities because we know glioblastomas are incredibly difficult to treat. So Roger said yesterday, he said, gain of each intervention is probably 2 or 3 months, but in 2 or 3 months will add up over the cohort of therapies that you're throwing at this tumor. But DcVax is a very straightforward therapy to do, can even be delivered in the community, hardly any side effects. So it can be combined with other treatments. And I just wonder what would happen if we combine a successful local treatment like TTF with a systemic treatment like DcVax, and there was all those trials to be done. Now, the recurrent patients are very interesting because I showed you really good response in recurrent patients. But remember, those patients had recurrence received DcVax that was made from the tumor resection at first surgery. They did not have a second surgery. And we know that these tumors change. So I suspect that if they did have repeat surgery at the recurrence, and we made DcVax from the new tumor, that impact may be also greater. So again, another nice study to do, hopefully. And of course, this technology is out there, and we have looked at the GBMs, but this potentially could be translatable to other brain tumors or other tumors altogether. So I just like to end here by acknowledging all those many, many people who have helped shape this study. So first and foremost, our patients and their family for allowing us to look at this treatment with them, because everything we do, as always, is only for them, nothing more, nothing less. UCLA and Linda Liao, who were the American chief investigator of the trial, all the investigators in 94 centers throughout the trial steering committee, and of course, Tim Kings, which are proudly sitting here in the front row, particularly to name Lucy Brazil, oncologist in crime with me, and Farzin Farzaneh, who is a professor of hematology back in Kings to help with everything, and all the values fellows and registrars who have been tormented by me over the years. And finally, Northwest Bio for sponsoring. So I'm happy to take any questions, and thank you very much for your attention.
Thanks very much, Ash. Floor is open to questions. Dr. Brazil, you got a shout out as well.
Lucy? No, I can shout.
So, I did the DcVax trial. What I was particularly struck by was that actually there was a very tight
entry criteria for the patients. So they had to have a sort of almost macroscopic dissection, but also the other entry point which quite a lot of patients stumbled on was that after the radiotherapy, a scan was done within 2 weeks, and if at that time there was residual tumour evident, then those patients were excluded from the trial. So that meant that really there was only a very small cohort of patients with GBM who were eligible for this trial. Can you comment on the matched controls, whether actually they were matched according to not just the standard prognostic criteria such as methylation, but actually that specific criteria for entry to the trial?
Thanks, Lucy. So you pointed out to two things, and I take them separately. One was with respect to resection. So you're quite right. These patients had to have a sufficient resection to have enough tissue to make the vaccine. So clearly that could not be matched with other trials because other trials were not using this form of immunotherapy. But that's partly because the technology we had, and remember this has been going on for 15 years, technology we had initially required quite a substantial amount of tumor to make the vaccine. Now over that 10, 15 years, technology always moves faster than medicine. So that production technology has improved to the extent that we can now make vaccine from really minuscule amount, so far less than we needed then. So I think moving forward, that criteria becomes much less important because we can make the vaccine for essentially an extended biopsy rather than even have a complete resection. So that's part. The second question was the very early progressor. So you're right, we did have to have an MRI scan earlier than we normally would to rule out those patients who had very early progression. So that is clearly an issue, but we know that a proportion of patients with GBM, regardless of what you do, they're going to progress really, really fast. And therefore, by excluding them, I guess to give opportunity to other patients, the vast majority of patients who don't progress as fast as that, to be enrolled in this trial. So yes, so I think the first one we have overcome now by manufacturing technology. The second one, I think if you're one of those few patients who are going to genuinely progress within 6 weeks, despite everything you can, then I think I'm not sure we can help that particular small, but nonetheless important cohort of patients. No, it was progression.
You guys are in the same unit. You should know what you're talking about, surely. Right, I think we'll have a last question from Paul Brennan, neurosurgeon in Edinburgh, before the break.
I guess the point that follows on from that is that if you haven't matched your cohorts, then you're not comparing like with like, and so epidemiologically there are some flaws to your cohort comparison. But within the patients who were treated, your crossover patients could help resolve that, because some of the patients in the crossover will have progressed. So it'd be useful to see your data presented by by MR imaging and performance status of the patients in the crossover, because if those patients do well, then I suppose that will allay the fears about your comparator cohort, and if they don't, then it will just reinforce them.
I've done my fun run already. I don't know why I'm doing this.
So in order to match the controls with our study, we use about 14 different criteria to make sure those patients were matched with ours. Of course, it's never going to be perfect, but it's as good as you can get using 14 different criteria. So using a crossover patient is a very good idea. It's a very small number of patients who kind of didn't cross over, who didn't have. So that's about less than 10% of patients, but we can certainly look at those to see what we can learn from them.
Any last, Dr. McBain, you get the last question.
Thank you. That's phenomenal, and thank you for presenting it to this meeting. My question is a very practical one about vaccine manufacture. Apheresis is quite a big procedure. What proportion of people, how extendable is this actually going to be out into the general population? Because that's going to be the next question, because everybody's asking for this in the clinic every week. So this is going to be big news. how many people, what proportion of people are able to have the leukapheresis? Of the people who have the leukapheresis, what proportion go on to have successful vaccine administered? And also, I know that some people only have, for example, maybe only get enough to have 2 doses. So can you speak to that? Thank you.
Thanks very much. So again, the long time period of the study let us learn quite a lot about this thing. So apheresis itself, you can maximize your yield by some very simple procedures. So what we do nowadays, the patients come and see the hematologist about 2-3 weeks before the procedure, have all the blood tests taken, and make sure the steroid is off, if at all possible. Now, in a very small number of patients, you cannot have the steroids off completely, but you have those maneuvers, you can actually get the leukapheresis done. I mean, I've had patients in their 80s who completely tolerated the procedure. So I think as long as you sort of the steroid, which is probably the biggest concern, you can get good yield from apheresis. In terms of practicalities, otherwise, no major issues, to be honest with you. I think obviously the cost is an issue. We need to make sure the cost comes down, and there are ways of trying to do that. For example, making production procedure automated will gradually reduce the cost. So I think that's probably going to be the biggest issue. But overall, the practicality is a very, very straightforward treatment, and to deliver it is very straightforward. It's intradermal injection, can be done in a clinic. So there's not a huge amount of issues in terms of being able to do that.
Great, thanks very much, Ash. I'd like to thank my co-chair and all the speakers in this morning's session, and it's break time. Thank you very much.